Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Kant, non-stop show 141st episode. Let's have the headlines of the day. Pregnant women were found to be 1.6 times more likely to die after trauma than non-pregnant women with traumatic injuries of comparable severity. Trauma surpasses other medical complications as leading cause of maternal death, affecting 7% of pregnancies, new studies reveal. Clinical evidence suggests that most often trauma occurs in the third trimester. It has been found that women who had adverse and traumatic childhood experiences had a 37% higher risk of pregnancy complications. The researchers say screening for adverse childhood experiences and providing trauma informed care may help prevent pregnancy complications. Let's go to the topic of the day. Today, we shall be talking about trauma and pregnancy. And to tell us more about this, we have Dr. Narmada Hadigal. She is a distinguished medical professional with an impressive qualification and a profound impact in the field of obstetrics and gynecology. She holds an MBBS, a DGO, DNB, DPHA, and MNAMS. She has underscored her extensive education and expertise to help the women around her. Dr. Hadigal served as a former professor of obstetrics and gynecology at both Usmania and Gandhi hospitals in Hyderabad, where she made significant contributions to medical education and patient care. Currently, she is leading fertility specialist at Narmada Women Health Center in Hyderabad, where her dedication and advanced skills continue to offer hope and solutions to many families. Her comprehensive experience and commitment to women's health make her a highly respected figure in her field. So, welcome, ma'am. Welcome again to our show. And today we will be talking
Good
about
evening, all.
Trauma in the context of pregnancy.
Good evening, all.
So,
Thank you
shall we
for
start, ma'am?
being in this. Good evening, all. Thank you to be here with you all. And I would like to just heading like this and trauma and resuscitation in pregnancy. And that will be a great thing. And
Yes.
so here the problem in a pregnancy and trauma, we have to first of all think about the physiology of the pregnancy because there are a lot of changes in the physiology of the pregnancy. And like cardiac output will increase, the quantity of the plasma is increased, and physiological anemia will be there, and peripheral resistance will decrease. So all these things are there, and so we have to think about the physiology and the response to trauma in pregnancy, how they respond to trauma in pregnancy, and then management. We have to discuss in all these groups. Management, how we have to management, like for major trauma, how to manage, and for minor trauma, how to manage. Like that, we have to divide, and what are the things that we have to investigate immediately once the pregnant woman has accident or whatever the trauma is. And also the third important thing, nowadays we are much talking about the peripartum cesarean section. So that also when to do, why to do, where to do, how to do. All these things we have to discuss under this trauma in pregnancy heading. So nowadays the incidence of trauma in pregnancy has increased. Why it is increased? Because the thing is, people are becoming pregnant late in their age. Like once they get medical complications, like if and hypertensive complicating pregnancy, like that, and like before only they will have hypertension, then they become pregnant. So there they may get cardiac arrest. Yeah, even the rate of cardiac arrest during pregnancy also increased due to late maternal age pregnancies. And also we are doing IVFs, ART techniques in late age. So patient wants to have children nearly 40 years, something like that, because all complications will be there and they are becoming pregnant. Of course, the cardiac complications, pulmonary, whatever, and diabetes, these complications can be there. And also, other thing is obesity. Obesity is also one of the important thing, and this hypertension will occur indirectly, like this. So, and also, usually they present 1 in 12,000, 1 in 12,000 in all countries. One pregnant woman will come with trauma in out of 12,000, like this. The instance has become like this. So what are the other things, like coming to the instance, how we have to divide motor vehicle accident in pregnancy is 55%. That is major accidents, because people will be driving, talking on the phones, like that. And the other thing is fall is almost, they fall in the bathroom while working and in slippery flooring, like that. And nowadays people are keeping very flooring like smooth and all other thing, that is 25%. And assaults, they fight those things, like almost 22%. And gunshots also have increased, and 4%. And homicides, somebody gunshots and these homicides 2%. And suicide rate is 3% again. And burns 1%. So poisoning is also 1%. So all these things are, we can the instance coming under the trauma, this thing. So how we have to manage, and what we have to do, all these things are very, very important in this heading. So coming to the motor vehicle accident, actually we can prevent if they keep belt, and 85% of the deaths we can prevent by keeping this belt. And also, uh, the how to keep the belt is also a separate kind of belt they are thinking. All motor vehicles they are thinking, like it should be below the abdomen, and anterior superior leg spine, one belt, and another belt is between the breasts, because of, and with that only they are supposed to walk, drive. And so so much of incidence is coming down when they are keeping the belt. So that is also more important. So what then we have to talk about the cardiac arrest. So what are the major things for cardiac arrest? That's also we have see. And always we think about the amniotic fluid embolism in our obstetrics. And that is very rare, of course. And but cardiac arrest is there. We'll talk about the cardiac arrest, and also status eclampticus. Okay, and in status eclampticus, naturally they have HELP syndrome, increased hemolysis will be there, low platelet count, and all these things, and elevated liver enzymes, all these things will be there. And also we use magnesium, because I want to divide uh, into obstetric causes and non-obstetric causes in the cardiac arrest. And in cardiac arrest, we have two things. So these things, and magnesium toxicity means magnesium sulfate we use for um, eclampsia cases, and I mean, for some people, they even use for preterm labor. In severe preeclampsia, status eclampticus, we use. And one of the adverse effects of the magnesium sulfate is cardiac arrest. Okay, that also we have to keep in mind. And uterine atony, PPH. And when patient is having PPH, naturally because of the hypovolemia and hemorrhagic shock, patient will go into cardiac arrest. That also comes under obstetric causes. And peripartum cardiomyopathy, which is very most dangerous thing, peripartum cardiomyopathy, which is more, of course, it is very dangerous. bad situation for these patients who they may get cardiac arrest with all these things. And also coming to the non-obstetric causes, and of course anesthesia complications. And when they give anesthesia like spinal anesthesia because of the hypotension, and also general anesthesia, of course we all know that the general anesthesia aspirations can occur, Middleton syndrome, and all these things. And also not only that, because of the medication what we use regularly, in some procedures like that. And aortic dissection aneurysms are unknown causes of like um, cardiac problems and vascular problems, that also. And bleeding, non-uterine causes like hemolytic anemias, that is not pph, and this is non-obstetric one we are discussing. And cerebrovascular accidents, of course, some aneurysms will be there in elderly people like that. Intravascular coagulations, and also in severe sepsis and thromboembolism, and opioid overdose. And also, of course, last one is trauma. We will discuss about motor vehicle accidents. We have to discuss under all these headings. So just now we have discussed that physiological changes in pregnancy, and almost plasma volume will increase 40 to 50%. And also, only thing, the signs of hypovolemia, once she starts bleeding, and when it will when signs will occur after 1.5 liters of blood loss, they'll get hypovolemic signs and symptoms, like pulse rate will be high, and bp will be low, like that. And hypoxemia and tachycardia, those things they will have. And also typical signs of shock they will get later. uh, and one more thing, uh, uterus receives nearly during pregnancy, uterus receives nearly about 30% of the cardiac output during pregnancy, whereas in non-pregnant women only 1%. So how much it is going to the pregnant uterus? Almost 30% in the from the mother, 30% of the cardiac output it is going to the um, baby, to the uterus. So only 1% in non-pregnant. So that counts a lot. So once, whenever there is hypovolemia, and when there is fall in the bp, naturally decreased blood supply will be there for the baby. And again, coming to the physiological changes in pregnancy, there are a lot of pulmonary changes, and gastrointestinal and urinary changes. And the pulmonary, this pregnant woman herself is a itself a alkaline state, like because of the high breathing and I mean tachycardia, little bit of tachycardia will be there. Hyperventilation is there. Because of that, they will have alkalosis. And respiratory will be decreased, cardiac consumption will be increased, respiratory will increase. And also tidal volume, minute volume, functional residual capacity, arterial pulmonary, and oxygen, all these things. And soda bicarbonate also will increase. Because of all these things, what are the things? Hypoxia will be there, and also decreased ventilatory capacity in the lung will be there. And coming to the gastrointestinal complication, like changes, because of the progesterone, increased progesterone, and they will have delayed emptying of the stomach will be there, and also delayed gastric motility, and gastroesophageal sphincter tone will also decrease. And because of all these things, they are because of all these things, aspiration, gastric aspiration can occur easily in this pregnant woman compared to other women. So coming to the urinary, of course, creatinine burn will be decreased, and compensatory respiratory alkalosis will be there. Because of the hyperventilation, they will get more chances of urinary tract infections and all. So for all these things, what we should do, and all obstetricians, gynecologists, and doctors, we should learn basic life support, that is BLS. Everyone has to undergo this basic life support in their lifetime. So here what they do, and in basic life support, and we have four things will be there. And the circulation, we have to we have to see that the circulation should be good. If anybody went into cardiac, if you think that patient went into cardiac arrest during pregnancy because of the all the above reasons, and we have to do chest compressions, almost 100 chest compressions in a minute we have to do. And also always we think about this I mean uterus will press over the aorta, no? That is the reason we have to push the uterus to the left side of the patient, and we need not put a wedge under the knee or the hip like that. And also airway, first thing circulation we have to notice, and also airway we have to put that mouth gag, whatever whichever is available. But only thing we have to see whether the patient is having good airway or not. And breathing also we should check whether she is having good breathing and all. And if really if she is in cardiac arrest, definitely we have to start defibrillation. We have to start defibrillation, and so ventricular fibrillation, ventricular tachycardia will occur, and we have to, if we have the provision to do all these things like ECG monitor. Of course, if they are not there, but anyway, we have to think about the defibrillation, and if it is available, we have to put defibrillator under her left breast, and those things we have to support. Not only basic life support, and all doctors should undergo training in this advanced cardiac life support also. There also same thing like a circulation we have to see, and airway, breathing, and other things we have to support. Here also, in because it is advanced life support, we have to see what is the rhythm in cardiac rhythm. And all the and intravenous access also we should um, take. Yeah, in intravenous access is must, because we have to establish, we have to perfuse the patient by giving I mean IV fluids, or if blood is available, all these things we have to see. And medication also is more important. And appropriate drugs we have to keep ready. We need not put pressure to put this endotracheal tube and other things, because in emergency all things may not be available. uh, but airway monitoring and breathing should we have to check it. So and everybody in every hospital or in ambulance, uh, people should make a teamwork, because only one person cannot do all these things. We have to keep team ready for these things. And all these things. Instead, one more thing, but with this cardiac compressions, at least the spine, I mean, this chest should go 80% almost inside. Of course, complications will occur with the chest pressure, like pneumothorax, fractures of the ribs, those things may occur. But these things are very, very important. And manual return displacement is very important. And when if patient went into the cardiac arrest for 4 minutes, and if patient is more than 20 weeks of gestation, I mean, in foreign countries it is more than 4 weeks, 20 weeks of gestation. But in our country, if it is more than 28 weeks of gestation, peripartum cardiomyopathy is advisable. So in peripartum cardiomyopathy, and we have to take subarumbilical midline incision, and basic I mean basic sterilization is okay. And we have to immediately take out the baby, and leave the placenta like that. Just to suture the abdomen and other things. And patient can be shifted to the patient can be shifted to the nearby OT. These things are very, very important in peripartum cesarean section, because by doing peripartum cesarean section, and at least baby will be saved. And if we cannot push the uterus to one side before doing this, and we can roll the patient to the little bit left side also. So the 4-minute rule is very very important in peripartum cesarean delivery. So our indications are different. The steps also we have discussed. And of course we thought about this other things also we should see, like internal. If patient is not having cardiac arrest, we have to think once she recovers from the cardiac arrest, then we have to see internal bleeding is there, and any hematomas in the liver, and pneumothorax, chest fractures, those things we can um, see later. So trauma, coming to the trauma in pregnancy, uh, and like almost complications, 6 to 7% of all pregnant women, they are suffering with the trauma in pregnancy. And this is a leading non-obstetrics cause of death among pregnant people. This is the 9 out of 10 traumatic injuries during pregnancy are minor only. And but the 70% of fetal loss is there in minor pregnancies, minor pregnancy trauma only, not in major pregnancy traumas. Also, so just now we have discussed what is the instance of motor vehicles and homicides, burns, poisoning, other things. So coming to these motor vehicle collisions, and motor vehicle collisions are the leading cause of death among all these people. Approximately 50% of these trauma will occur during the pregnancy. Why? Because in second trimester, lot of and little bit of the liquor amna is more, that is protected for the mother. But whereas in late pregnancy, in third trimester of pregnancy, because thinning of the uterine wall will occur and less liquor will be there. So if any trauma is there, directly it will strike on the uterus. And so accidental hemorrhage can occur. And also if baby head is fixed in the pelvis, and fractures of the baby head can also occur. And these things are more common. So that is the reason we advise every all women to keep advising special seat belts, what we have discussed previously. And in other nowadays we have to think about trauma in pregnancy in other aspects also, like intimate partner violence, and like quarreling of husband wife or partner quarreling. That also all pregnancy should be screened in this aspect. And also if we identify any doubt we have to counsel them and refer to psychiatrist or other thing. And these patients, uh, uh, during pregnancy, the quarreling and the violence is compared to other times, this thing is more. And why? Because already the pregnancy state is a depressing state. And all these most of the violence will occur, it may occur in during this period. So these injuries, we have to take a clear history little bit by bit. And we have how to take means, they sometimes they have self injuries, they cut their wrists and other things. And also self blame, they self blame for these injuries. And substance symptoms, sometimes symptoms suggestive also, substance abuses. They think we think that and most of the times these patients will be visiting emergency rooms without telling everyone. And they may visit these things. So these things are very very important. And so impact just now we have discussed, and placental abruption can occur, or pelvis fractures can occur, uterine wall thinning, and it may injure, and amniotic fluid leakage will start, and abruption may also start. All these things are there. So so what is the what are the things again we have to do in these cases also? We have to start ventilation, adequate ventilation and oxygenation, early intubation, and fluid support and blood replacement we have to do. So what are the blood tests we have to do? So like all blood tests routinely we do for this. And also not only that, even fibrinogen and I mean coagulation profile and these things also, x-rays and targeted imaging of the part, like focus assessment of the sonography in trauma, that is fast examination. Immediately we should see whether the uterus is intact, amniotic fluid is there, placental separation is there, fetal heart is there, or those things we have to see. And also look for any contractions of the uterus, any bleeding, bleeding is there from vagina. All these things we should do, whether membranes are intact or not. And central venous pressure also we have see, and all blood tests we have to do. And coming to the minor trauma, and these things are very very common. Many times patient they say we fell from the scooter on the road, like that. The minor trauma people they come, and for them same thing we have to evaluate, and blood test and other things we should see. But we see we should before discharging them, we always see whether they are continuously having uterine contractions, whether fetal heart is there, and any other risk factors, associated risk factors like hypertension in pregnancy, diabetes in pregnancy, other problem, low lying placenta, those things we have to, or multipara, those things we have to see. But for our admission is very, it is mandatory for all minor injuries in obstetrics. Like and they should not before discharge ensure that they should not have any contraction, and also bleeding, and fetal heart should be good. So these things we should see, and baseline fetal heart and the other things we have to see. So and of course we, if we have and fetal uh, fetal monitoring system, and it is well and good. But criteria, the discharge criteria we should follow these things. Coming to the amniotic fluid embolism, and we always talk about amniotic fluid, all the obstetricians they are really scared about the amniotic fluid
Yes.
embolism, because we don't know to whom the amniotic fluid embolism will occur, and the outcome is very bad. The mortality is high in amniotic fluid embolism, but it is 1 in 40,000 cases deliveries it is there. And actually the mortality is 85% in all cases of amniotic fluid embolism. Only 15% of cases we can save patients, and immediately if we put in ICU and do all these ALS and BLS supports. And risk factors for these things, multiparity, and also abruption, and precipitate labor, intrauterine fetal demise, and also when we give oxytocin and tracheocystoles, and also when we do artificial rupture of membranes, amniotic fluid embolism can occur. So they present with severe restlessness, vomiting, headache, distress, cyanosis, seizures, and patient may sinking kind of thing, DIC. They may go into DIC, and cardiovascular state will become bad. They collapse and coma and death. So now how to diagnose? Primarily this is based on these symptoms, and immediately we have to take, and within no time DIC can occur. Immediately we have to take blood samples for all these things. And the differential diagnosis always we have to tell about, like pulmonary embolism we have to keep in mind, and bilateral pneumothorax, and myocardial infarction, uterine rupture or inversion, septic shock, and eclampsia. And of course we have to do all other tests. So coming to the summary, and physiological changes in pregnancy can affect trauma and cardiac arrest. And every doctor and every team they should learn how to do and basic life support and advanced life support, advanced cardiac life support. And also trauma care centers we should be able to refer immediately. And also we have to make the team in every small hospitals or also in big hospitals, and consider about the peripartum cardio and cesarean section within 4 minutes, and which is very very important. Thank you, madam.
Thank you. Thank you so much. Thank you for the really knowledgeable talk that you gave us today. Dr. Namra Hadigal thank you for joining us today. Could you show us the certificate, please?
Thank you, madam. Thank you.
Could you show us the certificate, please? This is a
Uh,
small token of thanks from our side.
yes.
Very
Thank you.
little, very little
Yeah.
token of thanks that we want to tell you. That will be all for today. Dr. KK Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar.
Namaste. Thank you. Good night.